Let's continue this journey, shall we? What I mean by let's continue is that if you have not seen part 1 of this diagnosis journey video, please go and watch that because things will be way more contextualized and make way more sense. Then you'll be fully caught up with how my diagnosis journey went down. Let's do this thing. Hello, if you're new here, my name is Ashley and this is my YouTube channel. Before you go through it, we are currently in a series of Before You Go Through It, Vestibulodynia, and so I'm covering all things regarding my diagnosis of my vestibulodynia and my treatments as well as my surgery. I am currently a little over 12 weeks post-op and am currently going through pelvic floor physical therapy, so I am in the thick of the second half of my recovery. And so I'm currently catching you guys up in the past tense form, but catching you guys up so that you can hop onto the current standpoint of my journey and follow along. So I left you guys on a little bit of a cliffhanger. I left you guys at my Dr. Irwin Goldstein appointment, and so we're gonna go talk about that appointment as well as a breakdown of my specific diagnosis. I got diagnosed with acquired neuroproliferative vestibulodynia, and so I'm going to talk about what that means in this video, as well as the treatments that I tried with Dr. Goldstein, what that appointment with him looks like specifically if you end up doing your care with him, and also going to talk about how I landed on a vestibulectomy as the answer for my specific case. I left you guys on my referral from Jandra, not an official referral, but more of a recommendation to see Dr. Irwin Goldstein with San Diego Sexual Medicine in San Diego. But basically, I called to schedule a free 10-minute consultation with him. He does those before he meets with you because he wants to make sure that you are a good fit for his practice and that your issues are something that he can actually help you with. I had that 10-minute consultation with him. I gave him a very concise, articulate, summarized version of the whole entire long video of a story that I gave you guys in the first part of this diagnosis journey series. I remember the first thing he said after I gave my entire spiel was, "Okay, Ashley, take a deep breath." Not in an invalidating way. Let me just say, not in an invalidating way, but he said, "Wow, like take a deep breath because you had a whole journey to get here." And he said, "I think that you would be perfect to have as a patient. We need to see you ASAP." He did say, "Hey, I can't guarantee you that I'll be able to see you immediately, but we're going to try our best to see you as soon as possible." And which I expected because with specialists like this, and especially with this condition, there's not a ton of specialists that really understand the nitty-gritty about this condition. And so wait lists are pretty common for seeing someone like him. The funny story is that he told me to wait to be transferred over to the front office admin people so that way I can get my appointment scheduled in. I was fully mentally preparing myself to wait at least a couple months, maybe 3-ish months. But then I got switched over to the admin front office lady and she goes, "Hey, this does not really happen at this practice and has never really happened before, but we actually have an opening for tomorrow if you can come in. Somebody canceled literally a few seconds ago." And she said, "I've never really dealt with rescheduling, with filling people into cancellation spots like this." So she even said, can I put you on hold real quick because I need to make sure with Dr. Goldstein that this is allowed for me to just slip you into this slot." She said, "Are you free?" And when she asked if I was free, I said, "Girl, I'm gonna make myself free. Are you kidding me? This is super important." And so I obviously did. I called out for the next day, and I even had my husband come with me because Dr. Goldstein told me to bring my husband with me. Yes, you are allowed to bring a support person with you to the appointment, and I think it's honestly encouraged. And I quickly turned in all of my paperwork, all of my intake things, and my blood work. I emailed that in the span of 24 hours. So my husband and I showed up. If you haven't been to a Dr. Goldstein appointment before, or you want to know what to expect at his appointments, he does have you meet with a sex therapist. I don't know if you've seen any of his Yelp reviews or the San Diego Sexual Medicine Yelp reviews. I remember seeing one person get so angry about having to do the sex therapist appointment, and I don't know if it was because I don't know. I don't know if it was a dude. Maybe it was a dude, and maybe that makes sense of why he was upset. But I guess he was upset about having to pay for this, or was wondering if he could take it out. And I understand, right? Even my husband and I remember we were so skeptical because we're Christian and we just didn't know what to expect when stepping into an appointment with a sex therapist. That was our first experience as that. So let me tell you, as a Christian, we had a lot of skepticism around it. We didn't know if it was going to be a very secular approach or if there was going to be consideration for our religious beliefs. But I'm happy to report that we kept the appointment because there was no way to remove it anyway. And we just said, you know what, this is too much of a hassle to try to figure out how to not have this be a part of the appointment. We kept it anyway. And it was really great, honestly. And I don't know, I think people have a stereotype. Maybe, I know I did with sex therapists, where we think that it's going to be really weird, or they're going to talk about like positions or really weird stuff. Not that it's weird, but weird in the sense of that context. And so I had that stereotype. I thought it was going to be someone that really, really, really loved to talk about sex. And I don't really know why I had that expectation, but I'm just going to be honest. That was definitely my expectation. And that was not what happened at all, very much. What it really looked like was more of her asking how this condition was affecting me. I really appreciated it because I think that there is a lot to be said about how this mentally affects you. And I didn't even really, it makes sense in hindsight, but I didn't really put it together how much a sex therapist not only deals with sex amongst partners, but also just how sexual pain conditions can affect people. And this is clearly the territory where it mentally affects people to have pain with sex and things like that. And so it was very helpful, all to say. And we sat there. She was able to ask my husband how he felt about the situation and how it was affecting him. And it was really helpful. That was about an hour of the appointment. This appointment is 3 hours total, by the way, with Dr. Goldstein. So he's very thorough. I will say the perks of going through someone that doesn't take insurance is that they don't have the time constraints that the insurance companies will place on places that take insurance. After we met with the sex therapist, then we met with Dr. Goldstein. We sat down with him and he educated me so much more about this whole condition, and I'm about to relay that information to you guys. And if you're going to see Dr. Goldstein, you're going to get this whole spiel too. But if you are considering seeing him, or maybe you just want to learn more about the condition anyway because you think you might have it, that is why I'm giving you this information instead for free. Let me relay this to you. So first of all, one of the first questions he asked is, do you know why you have a vestibule? And I said, actually, no, like it's just there. I don't really know. He explained to me that in utero, right, I don't know if, in layman's terms, if you've taken a biology class or have had some sort of exposure about biology, the layman's way I can summarize it is we kind of start developing the same, and then unless you have XY chromosomes, you will continue to develop a certain way. What he basically said is that in utero, if you are coded with XY, then you will obviously develop the male genitalia, but the internal part, the lining of the urethra in a male, is actually made with that vestibule tissue. And if you don't have XY chromosomes and you develop as a girl, then you will have that vestibule tissue instead flatten out almost. Instead of turning linear, it'll kind of flatten out, and that's what will make the vestibule entrance tissue that is in the vulva. And that's why with men, you won't really see vestibulodynia, right? You don't really see issues like that because everything's enclosed. The vestibular tissue is enclosed in a man. But in a woman, obviously, everything's very exposed. And it was kind of a validating moment because he said, there's a lot of things that could go wrong in the female anatomy because of how open and exposed everything is. So that's just, the beauty of being a woman. When he explained that to me, though, he said the reason why this is important to know is because he was explaining to me that this is how they figured out that you can have a vestibulectomy, because he basically said the vestibule is not really important. And he said, obviously, we're not going to go around chopping off people's vestibules because if it's there, we leave it there. But he said that's how they developed the vestibulectomy as a treatment plan, because we can remove it without crazy consequences in a woman because it's kind of just leftover parts of something that would have turned into the genitalia, the inner lining of the urethra and the genitalia of a man. And then the next crazy fact he told me is that the terminology and classification of vestibulodynia only became a classification in 2003. Okay, let me say that again. It only became a classification of an issue in 2003. Okay, I was born in 2002. And so you may be thinking, oh, that's, about 22, 23 years, that's quite a bit of some time. In the field of medicine, it's really not long enough. And if you're wondering, so then did it never exist? So before vestibulodynia, it used to be called vestibulitis. And vestibulitis, the itis ending, basically implying inflammation. It kind of sucked because they were looking to diagnose this on a superficial level where they can see the inflammation of the vestibular region. But obviously, in my case and in so many other women's cases that have this issue, it's not something that you can see very much with the naked eye. It's pain that you can't see. It's pain that is not going to show on the tissue really, except maybe a slight little redness, but you might not even really be able to see anything and everything will look normal on the surface. What Dr. Goldstein told me is that this is very frustrating for women before pre-2003 that had this issue. I'm 23, but I think about, my mom's generation, the women before us that had issues like this and never really got treated for it. And it's really sad, honestly, and depressing if you kind of think about it a little bit too much, but also so encouraging and helpful and reassuring if you're someone who's dealing with this now, because now we have a field that is ever developing, that is finding ways to treat this and learn how to treat this better as a general pain condition instead of visual physical inflammation that we can see with the naked eye. With that being said, let's quickly talk vestibulodynia. So I'm going to have pictures probably as I talk about this, but in the book that I talked about last video called When Sex Hurts, Understanding and Healing Pelvic Pain, page 98 is where there's this whole entire diagram, and this diagram basically breaks up vestibulodynia into different categories, almost like a little map, kind of like if pain here, then proceed to this little part of the diagram. It kind of breaks up into a little tree. It's really, really helpful. And side note, I'm talking about vestibulodynia because that's my personal experience, but I know that in this family of vestibulodynia, the general umbrella is vulvodynia, and underneath that general umbrella is vestibulodynia. But vulvodynia has its own issues too. And so this book covers vulvodynia, and it covers bladder pain stuff, urethral pain. There's a lot of really good stuff in here. So I would totally get this book even if you don't have vestibulodynia. And super quick, since we're on that topic, let me tell you the difference in layman's terms between vestibulodynia, vaginismus, and vulvodynia. Okay, because those get kind of thrown around a lot, and what I'm talking about is very specific. And so let's just talk about that, because vestibulodynia, even in it of itself, has its own whole family tree of different causes and types of vestibulodynia. But even broader picture, there's vulvodynia, right? And aside from that, there's also vaginismus. Those are a ton of issues that women deal with. I'm going to talk about the difference between them super quickly because it can get really confusing. And if you're a woman trying to figure out what the heck is going on, there might be different things and information that you're receiving that are confusing you more, to be honest, because you're wondering, oh my gosh, is this vaginismus? Is this pelvic floor issues? Is this vestibulodynia? Is this just general vulvodynia? I don't know. And so the layman's terms, I'm oversimplifying this for the sake of clarity, but vulvodynia is a big umbrella of general vulvar pain. Okay, so vulvar pain being that whole, the vulva includes the vestibule. The vestibule is a part of the vulva. It's kind of like the square rectangle thing where a rectangle is a square, but a square is not a rectangle. In the same way, the vestibule is the vulva, but the vulva is not the vestibule. Did I get that right? I don't think I translated that correctly. So with vulvodynia, like I said, it's pain in the vulva. So that's why vulvodynia encompasses vestibulodynia, because if there's pain at all in the vulva, it could encompass vestibulodynia because the vestibule is part of the vulva. And so how you can tell basically is, if you saw my explanation from last video, I'll give it again super duper briefly, but you have the labia majora, which is where there is lots of pubic hair, you know, that's where there's the skin that kind of looks like the skin on your arm, right? Those are the bigger labias, I guess you could say, which is hence why it's called the labia majora. It's almost like major and minor. And then you have the smaller labia minora that's within the labia majora. The vestibule is basically everything that's within that little border of the labia minora. And that also includes the urethra, the outer urethral tissue. So not the urethra itself, not inside, not anywhere inside, but the outer parts, the fleshy part of the urethra that you can kind of basically see almost with your eye. The way you can easily differentiate if you have vulvodynia or vestibulodynia is that if you go outside of the labia minora and do a little Q-tip test sort of thing, where you're basically putting super light touches, not even a lot of pressure, but just super light touches with a Q-tip, if you have pain or experiencing symptoms outside of the labia minora, that's when you have vulvodynia, because you have pain in the general vulva. It extends into other areas. And what's so interesting is how you can tell with vestibulodynia is that you can basically like tickle the labia minora, which is what I was able to do pre-surgery, and not feel any pain. It's so crazy because, and this is what Dr. Goldstein will tell you if you see him, it's literally millimeters. They're so close together, and you can touch the labia minora completely perfectly fine and then go slightly in once you're in vestibule region and in vestibule territory, and it'll burn horrifically. So that's a big way to tell, and that's how you can kind of differentiate. If you have vulvodynia, that's when, like I said, this book will still cover it too. That's not my personal experience, so I'm not going to speak on that, but this book will definitely cover it. So please at least start there, and then you can figure it out. That's really helpful to know, because especially when it comes to researching things, or let's say you're on Reddit and you're trying to get people's experiences, if you're on the vulvodynia subreddit, there's a chance there actually are a lot of people that are dealing with vestibulodynia and just think it's general vulvodynia. Fun fact, speaking of vulvodynia, in my specific file with my primary care provider, there's not even an actual, how can I say this, a code? I don't know exactly how the files work, but there's not even a code for vestibulodynia for me to put in my profile of my health. So what I mean by that is that when my primary care provider, when I told her about how I saw Dr. Goldstein and I'm going to get a vestibulectomy, and this is, you know, updating her on all the things, she first of all had no idea what vestibulodynia was. A lot of primary care providers don't. And so when I was like, this is what it is and this is what it's called, and I had to basically teach it to her, which is crazy because, like I said, vestibulodynia is still so like new. She tried to type it in to add it into my file as an ongoing condition, and it didn't show up. So she said, okay, I guess I'm just gonna have to put vulvodynia because that's the only thing I can put on here. So all to say is you could be getting diagnosed with vulvodynia, but then you actually might have vestibulodynia, which is a way more specific targeted case of vulvodynia. That's a really important piece if you're struggling with your diagnosis journey and you feel like you're not getting like the complete picture and better answers for what you're going through. And so that's really important to know. And then vaginismus. So let's talk about vaginismus. Vaginismus, the difference with vaginismus is muscular. So that is more vaginal muscles instead of tissue. It will manifest similar symptoms as vestibulodynia. So you might still get burning pain upon insertion, all of these different things, but the cause is different. And I'd like to believe that the way you can simplify being able to differentiate vaginismus and vestibulodynia is that with vaginismus, you should still be able to do a Q-tip test just fine because you're not stressing out the vaginal muscles, you're just touching tissue. And so if you do a Q-tip test and you are touching different areas with very light pressure and things don't really hurt very badly, then you might be dealing more with vaginismus, right? And vaginismus, I will say, can be a symptom of vestibulodynia where all the stress with the painful tissue is causing your vaginal muscles to tighten. Same with pelvic floor issues. You can get pelvic floor issues because of vestibulodynia, but sometimes those things can be on their own and treated on their own too. So definitely sit with your provider because there can be a lot of different things going on. And like I said, this book is so awesome because it covers a ton of different things. And so you might have multiple of the topics that it talks about going on in your body, or you might have something that you think is a certain issue, but is actually a symptom of one real issue, and vice versa, right? And that's why there's even a bladder and urethra section, because the vestibulodynia can also cause urethral burning, which is kind of what was happening with me on the outside. But once it gets more inside and there's more bladder issues, there could be other things going on along that route too. So I hope this didn't confuse you more, and I hope it just brought you clarity instead of confusion, but I hope it at least gives you a little bit more of an insight into how these different conditions and things work so you can figure out what your specific case is. In my case, I did not have any bladder inner deep urethral issues, and I, as of now, because of pelvic floor therapy examination, I can officially say I never really had pelvic floor problems that were exacerbating my vestibulodynia or that were a result of my vestibulodynia. Honestly, that's more of a blessing because of the fact that I sing, and I sing at church, I sang in choir, and I play an instrument. I play the French horn. So I want to believe that my really good diaphragm breathing really has helped with my relaxation of my pelvic floor, and I've been told by my PT that I'm pretty good at relaxing my pelvic floor. So that's not an issue for me, but I've talked to so many people that they did have ongoing issues. Okay, so let's talk about vestibulodynia. This is the part where I said I'll put a picture up for the diagram and stuff. So vestibulodynia, I'll just read you the diagram because this is more if you don't end up buying the book or whatever the reason may be, or you're like, I'm just too lazy to read this. I'm just here to break it down for you super quickly. And then if you don't want to buy the book, then you don't have to. But, that's just kind of, so I have the book right here. And so I'm going to be reading it out, like not word for word, but I'm going to be reading out the diagram and explaining it super quickly. Okay, so first things first, on the top of the diagram, we're going to start with what part of the vestibule are you experiencing pain in? And so what I mean by that is in the vestibulodynia world, they talk about the vestibule in clocks. You should be getting a vulvoscopy so you can see what's really going on. But this is basically, if you want to do an unofficial examination for yourself, you totally can too. You can get a Q-tip, and within the border of the labia minora, let's split the vestibule in half. Basically, let's cut it along the halfway point from the bottom part, which is the perineum area almost. It's not the perineum, but it's kind of, it leads into the perineum, but it's not quite. You're still like in the vaginal territory where you're almost like at the bottom of the U. And so at the bottom of the U and up until the halfway point between where the top is, where the urethra and clitoris is, and the U at the bottom, let's split that in half. And if you split that in half, that's what they call the anterior is the top and the posterior is the bottom. And that's important information because even in general, it's helpful to know where it is, but also it helps kind of figure out what could be the cause for your vestibulodynia. And so in this book, when it's talking about pain confined to the posterior vestibule, which is, again, this bottom half, they say that in the book specifically, it says there's pain throughout the entire vestibule, but it's pretty significant at the 4, the 6, and the 8 o'clock. And so they, in the vestibulodynia world, they talk about the vestibule in clocks. So they go 12 o'clock, it's pretty self-explanatory, right? As you imagine a clock. If you have pain confined to the posterior vestibule, that's a whole different ballgame of an issue. That was not my specific case because mine was throughout the entire thing. So I did not have this specifically, but according to the book, you're probably dealing with some overactive pelvic floor muscle dysfunction aspect. If you have it more significantly in the posterior, there's a really good chance that there's pelvic floor stuff going on. Mine was pretty evenly throughout instead of just one part. So if we're looking at tenderness throughout the entire vestibule, then you're either looking at hormonally associated vestibulodynia, inflammatory vestibulodynia, which is more of the vestibulitis, right, of the original diagnosis that used to exist for this, or you're dealing with neuroproliferation. The interesting part is two things can be going on at the same time, and I'll get into what I mean by that because of my specific example. For the hormonally associated vestibulodynia, you're looking at blood work for your testosterone levels specifically. Not necessarily estrogen, because estrogen is hard to make a blanket statement on what's normal levels and things like that, because we as women change so much on our estrogen levels based off of where we're at in our cycle. But testosterone at least can stay relatively consistent, and so they do look at testosterone when studying hormonally associated vestibulodynia. And the normal range for free testosterone, okay, free testosterone specifically, when you do blood work, you'll get two different numbers. I might even be able to show mine specifically if I can find it, but you'll get two different numbers. One that's pretty much just a bigger general testosterone number, and then there's free testosterone. The key is the free testosterone value. And so this book talks about how the normal free testosterone range falls within 0.6 to 1.0. Now, Dr. Goldstein, when he sits down with you, I don't know if other health professionals are going to say this to you, so this is really important. Listen up. When Dr. Goldstein sits with you, he'll tell you that from his research and his experience of treating so many women with this issue, that he prefers the optimal amount of 0.8. 0.8. By the way, if you are over 30 years old, I think it's looking more like 0.4 at the bottom range instead of 0.6. So it can be a little bit lower if you're older than 30 years old. But in my case, I'm obviously not older than 30 years old. I'm not in that range of perimenopause and, you know, all the different life changes like that. And so mine was pretty low. It was not what he wanted to see. And so he did want to bring me up to that 0.8 range. He was honestly scratching his head and was confused on how mine ended up this way. I'm just letting you know, I've never been on SSRIs. I've never been on hormonal birth control. I've never done crazy drugs. These are three things that he asked me. He was so dumbfounded by my testosterone levels that he asked me, have you ever been on SSRIs? And I said, no. Have you ever been on hormonal birth control? And I said, no. And then he asked if I had ever done crazy drugs. And I said, no, I haven't. But it did make me realize that there's a lot of women that are on those things, that they are on SSRIs and that they are on hormonal birth control. So I'm just telling you right now, be sure to keep checking your free testosterone, because these things really nuke your free testosterone. And you might be wondering, okay, so then like, why does that even matter? Having too little testosterone in a woman, at least obviously can cause a variety of things, but in this specific context and situation, it can cause a lot of vaginal atrophy. So that's a pretty common symptom when you're talking about menopause, right? But if we really understand why does that symptom happen in menopause, it's because you have a big drop in testosterone. And so it causes a lot of vaginal atrophy, and in this case can cause the vestibular pain based off of the atrophy and the low testosterone, because there are testosterone receptors on the vestibule, fun fact. So the inflammatory vestibulodynia is the very common, that's way more better researched and studied with the vestibulitis piece, and that's more visible inflammation. There's usually a lot more yellow discharge. I could be butchering this explanation, but the inflammatory one is more like, okay, there is something that is actually causing it and we might not be able to see it, in the sense of there's an outsider component, like maybe there's a yeast infection that never really fully went away. I know that there's women that have had those stories before. There could be certain bacteria or various things that we can't see with the naked eye that are causing symptoms. And so that's like that route. Moving on to the neuroproliferation one. The neuroproliferation piece is more about nerves. That's what the neuro part is. So let's get back to the mast cell conversation, okay? And you can watch my last video, or at least the segment with my naturopathic doctor, because we talked about mast cells in that. But mast cells are the body's immune response to a problem, an infection, or an injury. With mast cells, I talked about how they're supposed to retreat from an area once they're done responding to something. but that if they don't end up leaving the site, that they end up still releasing histamine and white blood cells and all of the things that cause inflammation. The other thing they release is nerve growth factor. If you were to cut your hand, I used this example in my last video, but if you were to cut your hand and you had mast cells come and repair the damage, part of what they would do is release nerve growth factor. Why? Because you probably sliced through some nerves and caused some nerve damage if you sliced deep enough, right? Like, I sliced my hand one time, it was swelling a lot, and I'm sure because of how deep and how much pain it had caused, it probably had to regenerate some new nerve. However, in my case, which is the common cause for acquired neuroproliferative vestibulodynia, is that I didn't have these symptoms before the body wash, hence the acquired part. You would only fall in the neuroproliferation category. You would only fall into congenital or acquired, and congenital obviously being that you were born with it. You typically tend to find these symptoms more when you first try to put in a tampon, or you first try intercourse ever, or you first really have contact ever with the vestibule. Then that's when you are most likely in the congenital case where you were born with it. But in my case, I was fine up until the body wash. And so the body wash probably caused an inflammatory reaction in my body, and the mast cells did not leave my body when they were supposed to be done fixing the issue, and they kept releasing nerve growth factor. You can put it together why it would be a problem if there's no issue to solve and there's nothing to repair, and yet your body is producing extra nerves. And that was basically what was happening with me, was that I had extra nerves going on, and that's where the neuroproliferation piece is because the nerves are proliferating. There's too many. The way that you would find out if you have neuroproliferative is basically the vulvoscopy. That moves me on to my next point. In the vulvoscopy part, what it basically is that you sit down and spread your legs, and they basically have a special camera where they're able to really zoom in, so that way when they're doing the Q-tip test on you and officially writing down and documenting all the different regions, then they're also zooming in and seeing what areas of the vestibule they are touching. What the map basically looks like is they letter it from A, I want to say, to like M or something, but it basically goes A, B, C, D, E, F, G, like H, I, and it's kind of, they letter it around so that it's kind of the border and the inside part is kind of how it's split up. And so they go to each section and they ask you, how's the pain? Rate it from a 10, right? And then they mark it down. Let me tell you, that exam, I was really, really nervous about. It was definitely very anxiety inducing because, like I said, with my experiences in my last video with the swab at the OBGYN, I was very traumatized and very much in a more bracing response, bodily response of bracing because of how scared I was for it to burn super bad. At this point, I had been dealing with the pain for so long that I definitely was getting more anxious when it came to medical examinations for this sort of thing. But I will say that I really loved San Diego Sexual Medicine because obviously this is their whole deal. This is what they deal with on a daily basis. They meet with women with this issue. And I feel like because of the culture and what issue they really focus on, I feel like the culture is very sensitive toward women that are dealing with this. Shout out nurse practitioner Mia, because Mia is so sweet. Mia kept saying things like, let us know at any point if this is too much or if we need a break, and it was very reassuring. My husband was also able to be in the room during that exam, so he was able to just be with me and be present with me, and that brought me a lot of calm too. So I highly recommend bringing someone to this appointment if we're going to get diagnosed, because they're going to trigger a lot of painful spots and it is going to be uncomfortable. I promise it is worth it though, obviously, to get answers, but I'm not going to sugarcoat the experience, and it was definitely a lot for me. Validating at the same time, right? But at the same time, also a little bit overwhelming at times, and I definitely was tearing up in the appointment, and everyone was so supportive. The environment was really great, but it was just also the nature of it was overwhelming at times. So I got on the table and I basically, they brought the little camera forward and they spread my labias and went around. They started on the very border parts of it because, again, that kind of tells you the posterior, anterior, right? So they started at the anterior part and the border of it, basically, like the regions on the sides and on the top that are outlining right next to the labia minora and the urethra, that whole region. So they went up there. Of course, I gave it a 9 out of 10 and a 10 out of 10 on a lot of them. And because I had already given a 9 to 10 out of 10 pain, it was horrible. Then they basically took that and said, okay, if the top and the border and the urethral tissue is hurting that bad, they basically said, we're just going to map out the border and not do the middle section, because obviously the middle section we can just assume is going to be even worse maybe and just burn really bad. And I thought that was really considerate, because I really felt like they were really trying to be considerate of my emotional state and my pain. And I feel like they said, you know, we got the bare minimum information that we need to be able to diagnose this, so we do not need to put you in more pain. So that was my initial reading. When I said I was going to get into it with how they diagnose neuroproliferative vestibulodynia, this is how they diagnose it. So they actually then numb you up with this basically really strong numbing agent, some form of lidocaine with other goodies in it, and they numb you pretty good. You basically wait and you wait for the numbing to kick in, and what they do is they go back in and redo the Q-tip test, and if your pain significantly improves, even at like a 3 out of 10, then you're a really good candidate for vestibulectomies because of the neuroproliferative vestibulodynia aspect. The conclusion is, if the numbing numbs the excess nerves you have, then basically when you're doing this Q-tip test again, the vulvoscopy again, with the numbing agent on, it's assuming almost like this is what it could kind of be like if we removed all of these excess nerves, basically. When they redid my vulvoscopy and they redid my Q-tip test, everything went down to like a 2 or 3 out of 10, which was really crazy. I was not expecting that, and it was crazy because I said that they couldn't do the entire region, and this time they were actually able to do the middle part. They were able to test basically everything, and a lot of it went down a lot. Obviously, rinsed off everything, and we went back into Dr. Goldstein's office. We talked about the results of the vulvoscopy. That's where he said, you know, I'm pretty confident that there's very much a neuroproliferative case going on, but he just wanted to make sure that the hormonally associated vestibulodynia wasn't adding too much stress or contributing much more than he anticipates for my pain. He basically tried to first at least get rid of the hormonally associated aspect, and so that's when he prescribed me a gel, testosterone gel, to put on my calf to be systemically absorbed. Then he also gave me a estradiol testosterone kind of cream that was from a compounding pharmacy to put on my vestibule topically because of the testosterone receptors that are on the vestibule. So he was treating it again systemically and also topically. And then on top of that, he also prescribed me, I need to remember the name and how to spell it, and if I do have it spelled, I'll spell it out here. But it was a ketamine amitriptyline, something like that. I don't know how to say it, but again, I'll spell it out. But that's what he gave me, and it was compounded, and it basically was kind of to manage the pain. And then on top of that, he gave me a vaginal suppository called Intrarosa, and I think that was out of pocket too. But that was more to treat the atrophy, you know, again, just manage the dryness feeling and to maybe help at least feel a little bit better and relieve some of the symptoms. The ketamine cream was more because Andrew Goldstein, who does take insurance, uses that with his patients because they're constrained by, again, insurance. And so they're not really able to jump to vestibulectomies as quickly. From my understanding, I could be butchering that explanation. I could be totally wrong. So please look into it yourselves. That cream apparently was curing some people. Dr. Goldstein said they're not really sure why it was miraculously curing this small, like 10% of patients that were on the ketamine cream. He said, we still don't have research as to why it worked. It really manages the symptoms really well, but you have to be staying on it to get the effects. But then it magically cures, I think he said 15% of people, because they keep using it for a while, and then suddenly when they stop using it, then it just doesn't come back again. And I asked, okay, so how do I know if this cured me or not? And he said, you will know because you'll be managing the symptoms until you stop the cream, and everything will basically get worse again. I was gonna try the cream for 3 months. Let me tell you, the reason why I decided to go this route is because I wanted to quickly rule out the topical conservative measures in a more permanent way. So a lot of the time people will be on things for vestibulodynia, and I know there's gabapentin, there's a ton of other treatments that are ongoing right now. According to my pelvic floor therapist, again, she's a very big person in this field of vestibulodynia, and she's a very big advocate, educationalist, all of the things. So she knows a lot about this. And I remember when she told me about my diagnosis, she said that there still isn't good research on anything else besides a vestibulectomy. And that might be discouraging for some of you. So I do want to say that with care. I'm not saying this to discourage you, but I'm saying this to just let you know that if you are trying to do a conservative measure to treat this, it's going to take a while to experiment. And just know that that's what you're getting into. And I just want you to have the right headspace so that you're not thinking that these things are going to cure you right away. That's kind of my spiel on that. They're still doing so much more research on it, so don't get me wrong. And maybe if you are seeing this video years down the line, they probably could have developed something. But I know that there's a lot of ongoing trials and research into different things, but there just hasn't been one yet. And you know what? Maybe there will be, and I'm hoping that there will be, which is why research is so important. But as of now, there isn't something that is very well studied besides a vestibulectomy that has proven to be very effective. And I think the effectiveness rate, the effectiveness percentage of vestibulectomies are 80%. So it's pretty good odds. This is how I landed on vestibulectomy specifically. I leveled with Dr. Goldstein. I said, look, I'm married right now. I want to have kids relatively soon-ish, in the next 2 years. I want to have kids. And again, I'm someone who's very root cause, very holistic. And so I said, I don't want to be on things forever. I said, I don't want to be on medications forever. I don't want to be putting on creams forever. That's just not what I want, especially because I told him that I want to have kids. I want to have babies. I want to breastfeed. And obviously I want to get pregnant. So I said a lot of these things, and I confirmed with him, I said a lot of these things probably I can't continue while I'm pregnant. And he said, no, you can't continue them while you're pregnant. And so I said, yeah, that's a problem for me because I really want to have children soon. I need something that's permanent, and I need something that I can really say, like, this root cause is gone. Side note, okay, take this with a grain of salt, but I was also talking to my friend from college who's in med school right now, and I told her about this whole condition, and she then was like, yeah, it makes sense that you had to get surgery because I can't think of anything else that would fix nerves, right? Nerves are not topically treated. Nerves are really tricky. Nerves are not something that you can just slap on a cream and everything's fine, right? But nerves are complicated. Nerves are deep. And ultimately, it made perfect sense to me to go, if nerves are the problem, I need to just cut out the nerves because I'm going to be putting on creams and medication that's just going to make the nerves feel better and regulate them, but it's not going to remove the problem, which is the excess nerves. That was basically my thought process. And when I told Dr. Goldstein this, he said, yeah, that makes sense for your goals in life and what you want out of your treatments. And so he said, look, let's just rule out the hormonally mediated. Let's try the topical ketamine cream to make sure you're not a miracle case that's going to get cured. But then basically we landed on, if these things don't work after 3 months, then I'm basically moving forward with the vestibulectomy. And so I hope that brings clarity into how I decided that the vestibulectomy was right for me. If you're someone who wants to keep trying the conservative measurements, maybe you are forced to because you don't have the means to pay for a vestibulectomy, by all means, keep going, especially because as much as it could be discouraging to trial and error and basically be a part of an experiment and research on what works, we also need people to be a part of those things. We need people to do research with. And we need people to study, and I'm not trying to say, oh, get a vestibulectomy or you'll be an experiment, but what I'm saying is that you really could change the game for so many women after you if you decide to go through with conservative treatments and figuring out how that works out. And so that was kind of all my findings and my treatment plan. And lo and behold, after the 3 months with all the cream stuff and the conservative measures that I had tried, I basically came back and nothing really changed. I stopped the ketamine cream and my symptoms were bad, and it basically didn't do much. And I wasn't one of the miracle patients, obviously, because then I ended up having a vestibulectomy. With that, I highly recommend that you talk to your provider, and again, find a provider that specializes in this, okay? Because otherwise, I mean, I don't want to sound pessimistic, but otherwise you're going to get gaslit so hard and you're not going to be understood at all. So please find someone that actually specializes in specifically vestibulodynia, preferably even someone who performs vestibulectomies. You can find people that perform vestibulectomies, so that way you can have that option readily available to you if you tried other treatments and you also feel like vestibulectomy might be the answer for you. Just do your research and make sure that there's a lot of good testimonials. Make sure that this person has been in the know-how for a while. That was one of my things. I felt super comfortable with Dr. Goldstein because he's basically like the guy, one of the big doctors for this thing. So I felt super comfortable with my surgery with him. But I know that there's a lot of Reddit, subreddit posts about people saying their vestibulectomy failed and all these different things. And a lot of it is nuanced. Please don't be scared by that. A lot of it is nuanced because I wonder things like, did they have other issues before? Did they have other issues like their bladder or their urethra or pelvic floor problems or muscle tension? There could be so many other things going on. And before I end this video, the last little piece I want to be transparent about is how much this appointment costs. This whole initial consultation that I just told you this whole story about costed about $1,000. It was somewhere in the thousands. And yes, it was pricey. They did give me a reimbursement form to reimburse it with my insurance, but at the time I didn't have insurance that would have reimbursed it. I had Medi-Cal, like I said, so I did not even try, but maybe there's people that did try to reimburse it and got something back. Super worth it for someone that's so knowledgeable like Dr. Goldstein, and also because I was able to get things prescribed to me and things sent to the compounding pharmacy that I don't know if I would have had to jump through other hoops if it was a matter of insurance approval and insurance coverage in that way. I don't really know what that looks like, so I'm definitely not like the person to talk to if you want to talk about ways to get this covered by insurance or providers that take insurance, because that was just not my area of expertise. If I end up hearing from people, or if people in the comments have experience, please mention that too with insurance specifically. And that's just a little segment I wanted to end on. Thank you so much for watching. Thank you so much for watching my last video too, if you did. And if you haven't, please watch part 1 too for how I got my diagnosis. Like I said, this is a continual series of before you go through it, Vestibulodynia. So it's all things Vestibulodynia. I'm currently on just the beginning of this series. So please be patient with me as I make more videos for you, specifically about the vestibulectomy surgery. I'll talk about finances with that too, and the prep process. That's definitely the next video that's coming up, is the preparation process for my vestibulectomy, how much it cost, all the different things like that, all things surgery preparation leading up to the day of surgery. And that's just a little preview for you. So stay tuned for that. And again, I'll be making more videos with the surgery recovery process, catching you all the way up to where I am right now at over 12 weeks post-op vestibulectomy. And I hope that I have brought you some validation. Thanks again for watching, and I will see you next time. Bye.